Uh, Welcome all to the ninth session of the Comprehensive Neuroanatomy Educational course organized by the Neurosurgical Society in collaboration with the World Federation of Neurosurgery and the Young Neurosurgery Forum, along with the Neurosurgery Coach and the Pakistan Society of Neurosurgeons and Neurosurgical TV. Today we will have two distinguished speakers, Dr. Eduardo Ribas, he will talk about amygdala, Dr. and Dr. Helene Kuzuk. Did I pronounce it right, Doctor? Dr. Helene?
Pelin.
Helene Kuzuk, yes?
It's good.
Yes. Okay. So our moderator today will be Professor Aksharian, head of director of Institute of Neuroscience at Krishna Peshawar in Karad, India, and founder of Neurosurgery Coach. Dr. Aib, please, you can introduce our speakers.
Well, thank you very much. It's a great honor. Ahmed has been with me about 7 years back as our fellow, and I'm very proud of where Ahmed has come to. And Eduardo Ribas, I have heard about him a lot, and I really appreciate the work that he's doing, excellent work that he's doing. Eileen, unfortunately, I don't know her very much, but I would ask Eileen to enlighten a little bit more about her to us so that we know. Unfortunately, when I agreed, I didn't know that my session is going to be today. I knew I was in Delhi, but I didn't know the sessions were going to be today. So I just had one talk, and then I had this session on exoscopes. Extremely interesting. We have a lot of guys here. Charlie, everybody was here. So, but I would ask Ribas to his talk, and then maybe Aileen to shed light on her work as well. And again, I'm honored for this. Thank you very much.
Thank you, Dr. Aib. Thank you very much. So now our first speaker will be Dr. Eduardo Ribas, Associate Professor and Neurosurgeon at Faculty of Medicine, University of Sao Paulo. Doctor, will talk about anatomy of the amygdala. Please go ahead, Professor.
Well, thank you. Hello, everybody. For some are still in the morning, for others are already at night. I feel very, very happy to be here with you, with friends. In the last years, I came up with so many friends around the world and traveling and talk about neuroanatomy, more specifically how neuroanatomy can help our neurosurgeries. I believe most of us here are neurosurgeons, but anatomy is good for a lot of other professionals as well, right? But in my talk, I'm gonna talk about neuroanatomy, but how to apply this into our surgeries, into our neurosurgeries. And also, I'm very happy to be with people from all around the world. This new age, this new era that we are, and we can talk and we can share experience, we can share knowledge, and huge countries all around. I'm from Brazil. Dr. Pelin is from Turkey. People from India is here too. And so huge countries, a lot of neurosurgeons is very, very good to help everybody. So here in Brazil, I work in two main places. I work at the University of São Paulo. São Paulo is the biggest city in Brazil. And in the afternoons, I go to the Albert Einstein Hospital. It's one of the major hospitals that we have here, and I'm very happy to work on those two places. But my anatomy research I did under Professor Rotten from 2012 and 2013. I did this long fellowship there. It was a very good experience that I had to put together all the neuroanatomical knowledge and now to apply it into our surgeries. Now, today we're going to talk about the amygdala, and the first slides I'm going to just show to you guys where the amygdala stays inside our brains. So this is the lateral surface of the brain. We'll see the Sylvian fissure at the center of the surface, and if we split the Sylvian fissure, just retracting the opercula, we will face the insular cortex. The insular cortex has been said by some to be a shield for the neurosurgeon not to get deep to the insular cortex, just if you need, just if it's harboring gliomas, for example. And why is that? Because the insular cortex is the outer surface of a complete different compartment of the brain that will have a lot of eloquent nuclei and white matter fibers. This place is known as the central core because architecturally a lot of structures is putting together inside the morphological center of each hemisphere. So that's why we say it's the core, it's the central core of each cerebral hemisphere. But I would agree, but that's perhaps not the best name because we are putting together a lot of different structures, but all of them has a lot of functional significance. So every neuroanatomy book will have this axial cut of this region, that we have this alternating gray matter with white matter, gray matter and with white matter. We're putting together, so basal ganglia, white matter capsules, and thalamus is the main structure of the diencephalon. It's very interesting that each central core is at the morphological center of each cerebral hemisphere. And some structures are around the central core. They are called limbic because they are around. More specifically, around the thalamus. The thalamus is the main structure of the central core, as I showed. And around the thalamus and the central core, some structures have folded, have bended during the development of the central nervous system. And by this bending, it has this C shape that we call limbic. So let's take the brain and just fold it a little bit, tilt it a little bit, and we can see the C that makes the limbic system. We have some Cs. I'm just going to pinpoint two of them. We have an outer one called the cortical C of the limbic system that is made by the cingulate gyrus. Its narrowing called the isthmus of the cingulate gyrus, and then its continuation that's called para-hippocampal gyrus. It's called para-hippocampus because it harbors the hippocampus inside. So the para-hippocampal gyrus continues with the isthmus that continues with the cingulate gyrus, creating this cortical C or outer C of the limbic system. And then inside the para-hippocampal gyrus, we will have the amygdala and the hippocampus. Specifically at this point where the para-hippocampal gyrus folds over itself, creating a hook-shaped place, it harbors anteriorly the amygdala and posteriorly the head of the caudate, the head of the hippocampus. And the hippocampus continues more posteriorly into the para-hippocampal gyrus also, and then its fibers converge, forming the fornix. They will make all this C around the thalamus and finish at the mammillary bodies. So this is the limbic areas that I removed from this brain here. So we have the septal region, we have the cingulate gyrus, the isthmus of the cingulate gyrus, and the para-hippocampal gyrus. This is the outer C that I talked about. If we just flip it the other way around, we will see that inside the cingulate gyrus, we have the cingulum, is a set of fibers inside. And inside the para-hippocampal gyrus, we'll have the hippocampus and the amygdala. And as I said, the amygdala is more anterior than the hippocampus. The amygdala is just over the head of the hippocampus, just like a hat. But I would say it's just like we say a French hat, because it's not just over the head. It's a little bit folded anterior and medially. So it's not directly anterior, it's anterior and medial. This is that because the neocortex, the lateral part of the temporal lobe, developed so much and pushed the amygdala and the hippocampus to inside the brain, to the more medial compartment of the brain. So they were displaced more inside. And what I want to show in this picture also is that these structures are inside the temporal horn of the lateral ventricle. And as you can see, the temporal horn finishes here. So the amygdala is the anterior part and the anterior lateral part of the tip, the anterior tip of the temporal horn. The temporal horn finishes here. Between the amygdala and the head of the hippocampus, we'll have a cleft, we'll have a space. It's called the uncal recess. We can see this in MRI exams, and we can also see this in surgeries. This will help the surgeon to distinguish what is the amygdala put anteriorly and superiorly from what's the head of the the hippocampus. And the hippocampus, also a limbic structures, has three parts. I think Dr. Penning will talk about this later. But these fibers will condense into this other C. And the thalamus will be inside here, and the thalamus is said to be laying on this surface that's called the subiculum. Why this is important? Because the amygdala will have connections with all these limbic structures. That's why I'm just showing them a little bit. It will have some connections to them, to the hippocampus, to the subiculum. This is a superior view of the hook that makes the uncus. And I want to stress this part, put attention on this part, that the anterior part of the hook harbors the amygdala, and the posterior part will harbor the head of the hippocampus. And the fibers of the hippocampus will get together and form the fornix. And the thalamus will be in this space here, laying over the subiculum. And we're just gonna get between the subiculum and the fornix, we'll have some dentate gyra here. But at this lecture here, I'm talking about the amygdala. The amygdala and the fornix, they are putting together at the temporal horn. But between the amygdala and the central core, there is no subdivision. The amygdala continues itself with part of the central core, more specifically with the globus pallidus. There's no distinct, there's no cleft here. More posteriorly, you see a cleft. This is the choroid fissure. This cleft will help the neurosurgeon because this cleft divides medially the thalamus from laterally the hippocampus. So posterior to the amygdala, there is this cleft that will help the neurosurgeon or whoever is working inside there that wants, for example, to remove the hippocampus, but not to remove the amygdala. For example, temporal mesosclerosis, that we want to resect these structures. The choroid fissure will help you to get to know where the hippocampus is. But what about the amygdala? The amygdala continues superiorly with the globus pallidus. There's no cleft between them. They just continue. So you here and at the right side is drawing, and at the left side, my picture here, the amygdala, as I said, is superior and medial to the tip of the anterior horn. So this is the amygdala, and the amygdala continues with the globus pallidus. Okay, this is the lentiform nucleus. Laterally, we have the putamen. Medially, we have the globus pallidus. So they two continue like the number 8, or like a snowman, where the head of the snowman is the globus pallidus, and the body of the snowman is the amygdala. The amygdala is not just one nuclei; it's made by several nuclei. We can distinguish 30 different gray matter areas inside the amygdala. But these are grouped into bigger regions, and nowadays we just divide them into the dorsomedial group that's here. So you understand that it's very more medial, just more here, I would say. And this is the part that really continues more medially. As you can see, some people say the extended amygdala, because this part of the amygdala can continue with the substantia innominata and later continue with the bad nucleus of the hysteria terminalis that I'm going to show later. So some people will not claim the amygdala finished here. It extends even more medially. So we have this centromedial, the dorsomedial group. Then we have the central nucleus more superiorly, and we have the basolateral group. The basolateral group is more lateral, and some people will say it is a more neocortical structure, although it's not neocortex per se, is really connected to the temporal lobe, is really connected to the neocortex. So if you ask what is the neocortical area of the amygdala, that's the lateral part, because it's more connected to the temporal lobe. The amygdala, as I said, it is the anterior part of the uncal notch, right? And the amygdala receives a lot of information. It receives, for example, olfactory information. Olfactory tract posteriorly is subdivided into 2 strias, the medial one and the lateral one. The lateral goes laterally and then finished at the amygdala. So it has an olfactory connection here. It also has a dorsal connection that we call dorsal amygdalofugal fibers. I don't really like this name, amygdalofugal, because these connections are usually reciprocal. Information comes out and comes in, so they are afferent and efferent at the same time. These dorsal, I would say, amygdalofugal fibers, they are called the lamina terminalis. This is going on the space between the caudate and the thalamus, called the striothalamic nucleus. I'm going to show this a little bit later. And this has also ventral connections, ventral amygdalofugal fibers that the old anatomists would call them the ansa peduncularis, because they are making a C-shaped, a turn around the cerebros peduncle, the cerebral peduncle, the anterior part of the mesencephalon. But nowadays we can distinguish them into three components that I'm going to show later. Okay, so we have the lateral olfactory stria, we have the stria terminalis, and we have the ansa peduncularis. I'm going to show them a little bit more. Okay, the olfactory tract opening the olfactory stria, and they are the anterior part of the anterior perforated substance. So whenever you see the anterior perforated substance, you see the olfactory stria more anteriorly, and then we have the anterior perforated substance. And the amygdala will be at the anterior part of the uncus here, so it's going to be here. Then there is a connection of the lateral stria going inside here to the amygdala. About the ansa peduncularis, we did this nice study where we could put tractography, very fine tractography, and to distinguish the subcomponents of the ansa peduncularis. So in the old anatomists will just say this is one part, but we can distinguish them. The most known of them is the amygdaloseptal connection. The amygdaloseptal connections is also called the diagonal band of Broca, that also harbors some gray matter. So also a continuation of the amygdala to the septal region. There's two other connections: amygdalo-hypothalamic fibers and amygdalothalamic fibers. Amygdalothalamic fibers, they are going to the thalamus, so they can be called a thalamic peduncle as well. They're gonna get connected to other fibers, but some people say it's extracapsular thalamic peduncle, inferior extracapsular thalamic peduncle, because it's not between the lentiform and the caudate. This is another way of seeing this, but this is a connection of the amygdala to the thalamus. And as you can see here in our work of the DTI, three of them, they begin at the amygdala. These are the ventral amygdalofugal fibers known as the ansa peduncularis, but nowadays that can be distinguished into these other tracts. This is my dissection. We are seeing the anterior perforated substance from superiorly, not from inferiorly. More usually, we are seeing the anterior perforated substance from superiorly, from underneath, right, from inferiorly. But at this dissection here is from superior. So we have all these perforating branches going through the anterior perforated substance. And I wanna stress here are these fiber connections here, coming from the amygdala laterally to somewhere medially. Where they are going to three places. They are going to the septal region, they are going to the hypothalamus, and they are going to the thalamus. Okay, the septal region is what we call the diagonal band of Broca. Okay. And now let's talk about the dorsal amygdalofugal fibers. The dorsal amygdalofugal fibers is the stria terminalis. This is here colored in orange. So this is a dorsal connection of the amygdala that's going to make a very long route at the striothalamic sulcus. Striothalamic sulcus because it's between the caudate and the thalamus. It will make also a C shape. So it's limbic. It's a C shape. It's around the thalamus. That's why it's limbic. It's around. And this C-shaped structure, the stria terminalis, will finish underneath the head of the caudate at a place called the bed nucleus of the stria terminalis. As I said, the bed nucleus of the stria terminalis can connect to the amygdala. There is a connection from medial to lateral that some people call, for example, Leonard Heimer will call this the extended amygdala. As the stria terminalis reaches the anterior commissure, it subdivides into a precommissural segment and a postcommissural segment. The precommissural segment that is anteriorly will go to the septal region, and the postcommissural segment will go to the beta nucleus of stria terminalis. Okay, and this is what can be connected without a really gray matter connection between the medial beta nucleus of the stria terminalis to the lateral position amygdala. This is another picture of that connections at this great book. I love this book, The Human Central Nervous System by Niven Hoy. So whoever is studying neuroanatomy, functional neuroanatomy, has such good writing and very good illustrations. So you see the stria terminalis coming here, opening a precommissural and postcommissural segments. The precommissural goes to the septal region, and the postcommissural goes to the beta nucleus of stria terminalis. And then it can be really connected to the amygdala without interference, really connected. The anterior part so goes to the septal region. They have many nuclei that is connected to, but the posterior one will go to this place 4 and 5, that is the beta nucleus of the stria terminalis. Okay, and then it has also neocortical connections. It has connections to the temporal lobe, it has connections to the insula, and it also has connections to the hippocampus and to the subiculum. So it's really well connected. When I say afferent, usually we are putting together afferent and efferent, because as I said, a lot of connections come and go. They are reciprocal. Another interesting fiber tract at this location is the ansa lenticularis. The ansa lenticularis is not connected to the amygdala, but it will join the ansa peduncularis for a short distance. So while the ansa peduncularis that I said before is beginning at the amygdala, the ansa lenticularis is shorter. It does not go to the amygdala. It already starts at the GPI, the internal the globus pallidus internus, okay? And from the globus pallidus internus, the ansa lenticularis will make a route anterior to the internal capsule, and then continue to the red nucleus, to the substantia nigra, and to the subthalamic nucleus. There's 3 parts of this ansa lenticularis, and it will join the ansa peduncularis. So this is another work that we did with some Chinese friends. That here we put the ansa lenticularis. So the ansa lenticularis is not beginning at the amygdala, but those fibers are really together for a short distance with the ansa peduncularis. So some people will say the ansa lenticularis is part of the ansa peduncularis, but they are in fact a little bit different because they have different origin and different destination. The destination of the ansa lenticularis will finish so at the red nucleus, at the subthalamic nucleus, and at the substantia nigra. Okay, this is just some illustrations that we did. Inside the amygdala, all these nuclei, they connect themselves, and there is a progression of this connection from lateral to medial. So the information comes from lateral to medial. Okay, this is important from the functional point of view, because they are not reciprocal. They do not come both ways. So the information that comes from lateral, it finishes more medial, and then the information gets out. As I said, most of the connections are reciprocal, but the spread in the efferent system, it goes to more regions than the afferent system, mainly to frontal regions also. This is a brain dissection where we split the Sylvian fissure, and then we open the temporal horn. The temporal horn can be opened by many ways. Here we are opening the inferior limiting sulcus that Professor Yashagil calls the transinsular approach to the temporal horn. And as he's doing this cut at the inferior limiting sulcus of the insula, he will see the amygdala much more anteriorly. So if a neurosurgeon wants to do selective amygdalo-hipocampectomy, for example, to treat mesotemporal sclerosis, to treat epileptic seizures, he does not want to make this cut too long. He can make a cut just superior to the amygdala. Where he's going to make this cut? directly inferior to the limit insula, where the limit insula joins the inferior limiting sulcus, a little bit underneath and a little bit more posterior, you will see the amygdala. If you go more posteriorly with this cut, you will meet other fiber pathways. I'm not going to talk about them, but you can visit this paper that we have. So the surgeon who wants to do, I would say, a more direct route to the amygdala will keep himself at the anterior part of the inferior limiting sulcus and not go very, very posterior. Once the surgeon gets inside the temporal horn, he will locate himself. As I said, between the hippocampus and the thalamus, we'll have the choroid fissure. This is more easily to understand where the surgeon will stop his resection. He will not go more medial than the choroidal fissure. But what about the amygdala? As I said, the amygdala continues itself with the globus pallidus. So where will he see that he will end his medial disconnection of the amygdala? Well, some people like Dr. Wen, I work at the University of São Paulo, and I learned so much from Dr. Wen, Brazilian neurosurgeon dedicated more to epileptic treatments. So he will look for this point here. This is the inferior choroidal point. This is where the anterior choroidal artery gets inside the temporal horn. He will look for this point inside the temporal horn, and he will see or the ICA bifurcation or the band of the pia mater overlying the amygdala here, and he will make a cut here. This cut will be just lateral to this artery here. This is the anterior choroidal artery that is beginning in the ICA and getting inside the temporal horn. So by this cut, he will disconnect in the amygdala that is kept laterally from the globus pallidus that is kept inside the central horn. This is one way of doing this. Another way of doing this is to look for this structure here that's coming from the optic chiasm to the lateral geniculate body. This is the optic tract. So this is another way of understanding where the amygdala finished and where the globus pallidus will continue itself. So the surgeon needs to do this cut lateral to the optic tract, if you see this into surgery, okay? So this is a QR code. If you guys want to see the articles that I put together to do this talk, or I can put the link here if you guys want to reach these articles, okay? So thank you. Thank you. If some questions, or we keep the questions after Dr. Pelling's talk.
Thank you very much, Professor Ribas, for this fantastic presentation and very nice this exchange. And there is a lot of information that you explain the anatomy and the physiology and also applied anatomy of this amygdala. Unfortunately, Dr. Aib Shirin couldn't stay with us. And for any questions for Dr. Ribas, please, I encourage your audience to type their questions in the chat. And after we finish with our second speaker, we can discuss if there is any questions. Okay.